Thanks very much for having me. It's absolutely fantastic to be here at this meeting, and I've enjoyed the bits of it that I've been at. I think it's a fantastic forum. So we're going to talk today about inherited genetics in gynecologic cancers, and really some of this you may already be familiar with, and hopefully some of it is where we're going. So here are my disclosures. Just to be kind of clear for everybody that we sort of start on the same page. So genes provide the instructions for our cells, the sort of map or blueprint for our body. And all of us, all the time, undergo DNA damage. And so that damage needs to be repaired. And if a cell is not able to repair itself, it should then die off. And that's a good thing when a damaged cell dies off. Cancer is inherently a genetic disease. When the instructions go awry, the cells that are abnormal or damaged, instead of dying off, they have the ability to grow in an uncontrolled manner. And that's where the problems start, that they are not switching off the way they should. And when we think about genetics and cancer, there can be a lot of complexity in the terminology used. And so I just want to be kind of clear. Somatic is usually referring to the tumor. And I talk to patients about the tumor's genes versus your genes. So something that happens in the tumor is only in the tumor. It's not inherited, it's not shared with other family members. But often advanced cancers have multiple somatic mutations or alterations. Whereas when we think about the germline, we talk about pathogenic variants. This term mutation, we don't like to use in the germline anymore because it has some sort of connotations with it. There's a variant in your genetic material, and is it pathogenic or disease causing or not? These can also be seen in the tumor, but they're also present in the egg and sperm and can be shared with other family members. And depending on what type of testing you do, the variants that are identified may be from the tumor or maybe from the germline, and it may not be clear. Sometimes additional testing has to be done. And for a patient who has a cancer diagnosis, a lot of the focus might be on treatment, and maybe it doesn't matter so much in the moment. But of course, for their family members, where that germline, if the variant is germline, I should say, is of course important, and then potentially for a future cancer risk. So this is sort of a framework of what I want to talk about today. Can genetic information help us to answer some questions for patients and their families? So can we use information to define what someone's cancer risk might be? And can we use that information to intervene and prevent or decrease risk? If someone has a cancer diagnosis already, is the information important for prognosis or for predicting response to therapy? And hopefully, as we do better with our therapies, can we look at patients' future cancer risks and protect them into the future? And then, of course, the cascade testing of their family members and back to risk identification. So what I'm going to focus on today, BRCA1 and 2 and Lynch syndrome, these are high prevalence, relatively common germline predisposition syndromes. And they're really just a framework of an example. And a lot of these principles apply to other genetic changes in cancer. So if we take BRCA1 or 2, so the risk of ovarian cancer up to age 80 is 40% for BRCA1 and 20% for BRCA2. So this is the risk identification bit. As you can see, it starts somewhere in the 30s for women who have a BRCA pathogenic variant. Just to give you some context, I want to look at the breast cancer risk because often when patients come to me, people are familiar with breast cancer risk with BRCA and not as aware of the gynecologic risk, maybe outside of this room, but in the general population, that's often an issue, and really trying to have some increased awareness and education about that. Obviously, the breast cancer risk is high with BRCA, and breast cancer in general is relatively common in the population, and that's part of what drives that narrative. And as you can see, the risk of breast cancer starts earlier for women with BRCA1 and 2. It's about 70% lifetime and starts really in the mid-20s. And I just put this in to illustrate this point that, as I said, people tend to be familiar about the breast cancer risk, but actually breast cancer is relatively common in the general population, and ovarian cancer is relatively rare in the general population. And actually the magnitude of increase in risk is higher for ovarian cancer, albeit the absolute risk of breast cancer is higher. The other thing I just want to say is we have to remember about the men, and there's a lot of misinformation in the space, and I think it's really wonderful where people who have a public platform sort of share their story and can really help the narrative and the education. So this is Beyonce's dad, who had a breast cancer diagnosis and went public with his BRCA2 diagnosis. There's a lot of healthcare professionals still who don't even recognize the importance of men within the family tree. But if we go back to ovarian cancer for a minute, really it's actually a mix of diseases. So typically what we think of as high-grade serous ovarian cancer, which is the most common kind of ovarian cancer, and that is the one that's associated with BRCA1 and 2. But if we look at some of the other kinds of ovarian cancer, endometrioid and clear cell, then they're the ones associated with Lynch syndrome, which I had mentioned at the beginning. And I feel quite strongly about this as a gynae medical oncologist. Lynch syndrome used to be called hereditary non-polyposis colorectal cancer syndrome, but really it's a colorectal and endometrial cancer syndrome. And we need to be careful about the messaging in this space too, because people really think about colorectal cancer and don't maybe advocate the same way for the gynecologic cancers in the space. So this is one of the original families described by Dr. Wortham. And if you look at all those purple arrows, they're women with endometrial cancer. And just to highlight how many people and women were affected in this family. But we're learning more about Lynch syndrome, and this is really where some of the world is changing, in that Lynch syndrome is caused by the mismatch repair genes, MLH1, MSH2, MSH6, and PMS2. But we now really understand these as 4 different entities, and that's quite important. We used to give very generic recommendations to anyone who had a Lynch syndrome diagnosis, whereas we now separate out risk understanding based on the specific gene, and actually based on the specific gender as well. So the potential to get a specific Lynch syndrome associated cancer, mainly colorectal and endometrial cancer, is gene and gender dependent. But we also have to be a little conscious about this, because the data, this is a very large study, and a lot of guidelines and recommendations are based on the study. But actually, when you drill down into the information, there's very few women, for example, with PMS2 in the study. And so we just have to be careful about that, and always mindful when we're making recommendations, what's the robustness of our data, and also encourage people to participate, of course, in data gathering and research, that it really helps to inform for everybody. The lifetime risks is also gene and gender dependent. And as you may be able to see here, or maybe it's not projecting well, but if you look at MLH1 and MSH2, they're pretty similar, male, female. But for MSH6, women actually have a higher cancer risk than men. And that's driven by the endometrial cancer risk in MSH6. So really important to emphasize that. And actually, really, gynecologic cancers are often the dominant issue for women with Lynch syndrome in comparison to colorectal cancer. And women may be diagnosed with gynecologic cancers first, and that might be the first time that Lynch syndrome is identified within a family. So it's really important that we look at women with endometrial cancer and take that opportunity to make the diagnosis within a family. So if we know that somebody has cancer risk, what do we do about that cancer risk? So can we prevent it, or can we detect it early at a chance that it's more amenable to cure? Well, it does depend a little bit on the gene and the disease. So this is Angelina Jolie, and a lot of you might be familiar. She also went public with her BRCA story. So her mother had BRCA1 and ovarian cancer, and she decided to go forward with risk-reducing mastectomy. So when we think about breast cancer risk, again, I was saying that this is something that people tend to be more aware of in the general population, but they often think about mastectomy, and they don't think about the potential for screening for breast cancer risk. When we talk to patients about this, we talk to it as both options. It's a personal choice for what it's worth. You obviously don't choose to be in the situation, but you could do screening versus risk-reducing surgery. But it does depend on the disease and the gene. And so in this setting, the disease is an issue. So for women with BRCA, there is no successful screening for ovarian cancer. And so that means that we are left with the option of risk-reducing surgery only. So why do current methods for ovarian cancer screening not work? Well, high-grade serous ovarian cancer most likely arises within the fallopian tube, and the cell drops out onto the ovary or into the space and grows somewhere there. And so if you do a transvaginal ultrasound or CA125 monitoring for a population of women, that unfortunately is not successful in diagnosing cancers at an earlier stage in general. So as I said, that leaves us with risk-reducing surgery, so prevention rather than early detection. And for women with BRCA1, we recommend usually at 35 to 40, and for BRCA2, we recommend at 40 to 45. Most women, unfortunately, who have an ovarian cancer diagnosis are present with more advanced stage disease. But is it possible to detect it at an earlier stage that might be amenable to cure? Well, this is Chris Everett. And when her sister was diagnosed with ovarian cancer, they had BRCA testing in the family, and she went to have risk-reducing surgery and had a small ovarian cancer diagnosed. So an incidental ovarian cancer at a risk-reducing surgery. Well, the interesting thing about that is when you look at women who have risk-reducing surgery for genetic risk, the age at which they have that surgery matters. Most women do not have an incidental cancer found, but of the women who do, they're usually women who had the surgery done at an older age or older than the guideline recommendations. But of course, you have to know that you have something to do something about it. And so this is the difference between Angelina Jolie and Chris Everett, if you wish. Angelina Jolie knew in her 30s about this and did something about it, whereas Chris Everett was older when she found out. And that's, again, why it's so important to have education, advocacy, awareness in the space so that people can identify risk at a time for intervention. Then if we talk about Lynch syndrome again, if we switching tack a little bit, colonoscopy is important. And again, that's a lot of focus in general in the population. We now make gene-specific recommendations for the age of starting, and then usually the interval depends on actually where people are living. So in Ireland, it's 2 years, but it can vary. But if we go back to gynecologic cancer risk, we're talking about endometrial cancer and ovarian cancer potentially, whereas with BRCA, we were talking about ovarian cancer, risk-reducing oophorectomy. With Lynch syndrome, we're talking about hysterectomy as the primary, and then oophorectomy depending on the gene and what the risk of ovarian cancer is potentially. So for PMS2, the risk of ovarian cancer is thought to be about 2.5%. So in comparison to general population risk of about 1.5%. So in general, we don't recommend risk-reducing oophorectomy for a risk lower than 5%. But if women are having a hysterectomy anyway and they're postmenopausal, they might have a conversation with their doctor about whether or not oophorectomy is the right thing for them. But it needs to be a nuanced conversation now based on their age, their family history, where they are, and what gene is involved. And that's really where we have changed in the last 5 years, probably, like relatively recent. But what if you already have a cancer diagnosis? This genetic information may be important to you in that space too. And this may be the opportunity to identify genetic information within a family. This might be the first time we find out about it when someone has a cancer diagnosis. The information can be important to understand a cancer prognosis and predict for benefit from therapy, and they can be intertwined. If you're going to benefit from your therapy, well, then your prognosis might be better, right? So germline pathogenic variants are associated with better prognosis in ovarian cancer patients. If you look at this, is an older study with chemo plus or minus bevacizumab. Patients with a BRCA pathogenic variant did better than those who did not. And then, of course, we now have the fantastic data about PARP inhibitors, where you get a very impressive disease-free survival with a PARP inhibitor versus placebo in this original study of BRCA-associated ovarian cancer. And at 7 years follow-up, this data still looks very good. So really separating out with the therapy. Mismatch repair deficiency is the hallmark of Lynch syndrome associated cancers, so either by immunohistochemistry or microsatellite instability. And we now have learned that these are associated with durable responses to immunotherapy. And this was really an exciting time where we had a disease agnostic. So that means not based on a specific disease, but based on the biomarker, we had a therapy approved. So this is really game changing in this space. And although we're doing better with these therapies, really cancer prevention is the space we want to be in. It would be far better if people weren't in this boat in the first place. So if we look at the cancer patient, if we can identify risk in them, and if we're doing better with our therapies, well, then we want to prevent their future risk. But of course, the opportunity to identify risk in the family members, although that's a hard thing to take on board, it's a huge opportunity to change their lives. Unfortunately, historically, the uptake of genetic testing in ovarian cancer patients has been pretty poor. This is data from 2017. And as you can see, there are many women with ovarian cancer did not have genetic testing discussed with them. And the study estimated that 1.2 million people did not have genetic testing. And really, that's a shocking statistic. But actually, a lot of it was probably well-intentioned. People were unwell. They had a lot going on. Let's not open that can of worms. Thankfully, that has changed hugely with the therapeutic indications. So if genetic testing is important for deciding whether or not you have a PARP inhibitor, we're going to have that conversation regardless of how well or unwell you are. And that's really been a massive game changer for patients and for their families. And as I said, patients who have a BRCA-associated ovarian cancer now hopefully have the opportunity to benefit from PARP inhibitors and to be doing better. And we used to say, if you have an ovarian cancer, well, that's the driver of your outcomes. We're not going to worry so much about your breast cancer risk. Let's just see what happens. Well, hopefully now you're going to do better from your ovarian cancer perspective. This is data out to 5 and 7 years that I've shown you. And then we might need to be thinking about your breast cancer risk again. And actually, that's a good thing because you're doing well from your ovarian cancer point of view, and we're going to start screening for breast cancer again. And if we go back to the breast cancer situation, I said at the beginning that women with BRCA-associated breast cancers actually tend to be younger risk than ovarian cancer. And that's a huge opportunity to identify inherited risk and to prevent ovarian cancers in these women. And most women overall, if you take a population of breast cancer patients, their outcomes are actually very good. And so hopefully they're surviving their breast cancer, and we want to intervene and have them not have an ovarian cancer diagnosis. Similarly, there's pretty good outcomes with Lynch syndrome associated colon and endometrial cancers. And as I also mentioned earlier, gynecologic cancer might be the first cancer identified in a family that then highlights the Lynch syndrome, and you want to prevent the colon cancers in that woman and her family members. So cascade testing facilitates risk identification and cancer prevention in family, and is hugely important. So if we take this BRCA example, if you test all women for ovarian cancer, identify BRCA, then identify their family members and prevent cancers and cancer-related deaths. So integrating germline genetic information into routine cancer care, as has become the norm for some cancers, in particular ovarian cancer, is providing us with critical information for patients and their families, and really these opportunities to intervene and hopefully make things better for everybody. Thank you very much.
Thank you very much, Karen. That was great. I think we've just got 5 minutes for questions. Is anybody got a question in the audience?
Oh, thank you. Yes, no problem.
So I guess while people are just having a wee think about questions, I've just got one. So you were talking about how we're beginning to get a bit more nuanced understanding about the different genes. And are you aware of any work that's happening in different ethnicities or different geographical locations to see how that might
Yes.
impact?
Yes. So one of the real challenges that we have currently is when we tell somebody that they've got BRCA or even Lynch syndrome, where we have more gene specific information, we give them what's relatively generic information about their lifetime risk. And what we really like is to have more specific information for you as a given individual, what's likely to happen. So if you have a woman who's got a BRCA pathogenic variant, if you could say to them, yeah, it's BRCA1, but your lifetime ovarian cancer risk isn't until 48, so you can hang on to your ovaries till you're 43, that would be useful, right? So they're doing studies on polygenic risk, which are small changes in the genes that, in addition to the BRCA, might make some women's risk higher and younger than other women's risk who also have a BRCA pathogenic variant. And there's a lot of complexity in polygenic risk, though, based on race and ethnicity, and it actually is disease dependent. So, for example, in prostate cancer, ethnicity matters more than in some other cancers. So there's, I think, a lot of good things to come in this space, but it's going to take us a little bit of time to, and a lot more data to sort it out. But I think promising for the future.
Thank you. Any other questions? No? I think in that case,
Okay,
thank you so
super.
much.
Thank you.
I know